Hello, everybody. My name is Matt Sakamoto. I'm a virtual primary care physician based out of San Francisco, and I'm very excited today to be hosting this panel on women's health and telehealth. I'll actually have each of our guests introduce themselves. So I'll have you introduce yourself and then answer the question, have you ever been on the giving or receiving end of a virtual women's health encounter? And what was that experience like? Aditi, I'll start with you.
Hi, everyone. Thanks, Matt. It's good to see you as usual. My name is Aditi Joshi, and I'm an emergency medicine physician, but I've worked in telehealth since 2013. I've led teams at a startup and then an academic medical center. And most recently, I work as a consultant for digital health in general. And I have a telehealth success book coming out in November through Forbes. And so part of what we did for that book was research women's health and women's telehealth. And so I'm glad to be here. And you wanted me to
Thanks.
answer that question right now about using telehealth, or was that
Yeah, short story about it. Yeah, go for it.
okay? So, someone asked me this question just this week. So it was interesting you asked about using virtual health for women's health. And the truth is, I've actually never used telehealth because for all of the things that I would use telehealth for in general, it was something that I could take care of myself as an acute care doctor. And most of the time when I needed to see a physician, it was for a procedure or a checkup or screening. And it was something I needed to actually go into see a doctor for. So I've actually never seen anybody for telehealth at all. So despite having seen like tens of thousands of patients over telemedicine.
Perfect. Well, so we really look forward to it and super glad to have your expertise from the, again, on the clinician end. Perfect. Bronwyn, how about yourself?
Hello, I am also a physician. My specialty is pediatric cardiology. The actually practicing is a small minority of my time. In the past decade has been spent in digital health across different things, mostly app-based experiences from my own startup, 3 years at Apple, most recently at Carbon Health, and now at Care Evolution. At Carbon Health, I did my most experience within virtual care and helping them to set up a virtual first primary care experience. So great to be here. So I actually have never been on the giving end of telemedicine. Pediatric cardiology is really hard over video. I do a lot of initial visits where you really need the EKG. It's for a murmur. How do you listen? So that actually, as a physician, only a handful of times have I done telemedicine visits, but I have personally, both for virtual primary care, for urgent care, I've done different specialties for myself and kids. And so that I would just say it's not the convenience of the log on and literally like help get kids ready for school or different things while you're waiting, and then have the visit and be done. And I think one visit I had, like my kid was up, on watching TV while I was having the visit. So that to me is still just mind boggling. Like it's absolutely amazing that the visit can actually take the amount of time that a visit needs to take and nothing more. So I just for those reasons, a huge fan of making it a lot more convenient when possible.
No, totally. I love the way that it just kind of like fits into like your daily life. You don't have to chunk out a half hour, an hour of driving, parking, and everything else. And I think, again, even kind of thinking back from a primary care standpoint, I get a lot of patients that probably wouldn't have come in for a visit or, shown up for a visit. I guess not really coming in, exactly with that convenience factor built in. Perfect. Andrea, how about yourself?
Well, hi, everyone. Excited to be here. My name's Andrea, and I'm the CEO and founder of Simply Fed, which is a virtual breastfeeding and baby feeding support company that operates in all 50 states. My background's in biomedical engineering, and my introduction to telehealth was actually back in 2010 when I was a grad student, where my research was for the chairman of the Joint Chiefs of Staff in the military and how to leverage telehealth to improve access to care for service members faced with post-traumatic stress. And so that's what my background and training came up in. Then I was a presidential innovation fellow based out of the White House, and my appointment was at Department of Veterans Affairs. And VA is one of the largest adopters of telehealth. At the tail of that, was pregnant with my first daughter. We decided to move to rural upstate New York, had my first daughter, and saw how hard baby feeding was. And I also saw the power of telehealth to help both with rural populations, but frankly, with folks that are have newborns, because of all the things that have been mentioned by the panelists, that it's really hard to get out of the house, especially when you're in a rural area, but it's really hard to get out of the house when you have a newborn and get access to the care care that you need and deserve. And I also learned that health plans are required to cover breastfeeding, baby feeding support as a requirement of the Affordable Care Act. And the vast majority of health plans weren't in compliance with that. So have seen the power of telehealth to improve access to care. We see this day in, day out with patients saying, I don't have enough money for gas to get to another appointment, or I have a newborn and I don't want to be able to bring them in the car and expose them, or it's just a lot for me to get out of the house. So being able to improve access with telehealth is huge. And to directly answer your question about what has been my personal experience with telehealth is not only do I lead the Simply Fed organization, I am a patient. So I've gotten care prenatally to make a plan for baby feeding, and I've gotten appointments almost every week to help support my baby feeding journey. This is my third daughter. And what I can say is that the experience with telehealth, now using Simply Fed, but frankly, insert whatever platform here, has been instrumental, and it's allowed me to feel better about my health. I now am baby feeding and reaching my goals in a way that I was never able to reach with my first. And I think it's because I've been able to leverage the convenience of telehealth to really improve that access to care for me and my family.
Awesome, super exciting. And I think the one thing that I'm also excited about this panel to share is the diverse perspectives. I'll probably actually go back around in reverse order, but I think also Andrea, Andrea, with your experience kind of on the federal government side, I think like that gives you a nice angle towards a policy lens. I think that the rest of us don't really have. Kind of actually with that lens first, what's like the most important gap in women's telehealth, maybe at the US federal policy level? And then I know DT has some international perspectives, but kind of, I guess from a US federal policy level, what are some of the gaps that you've seen or noticed kind of throughout your journey?
So one of the things that we definitely saw when I was in the federal government, and now as a recipient of federal government policies, is when there is no policy or when there's ambiguity with the policy, people defer to the most conservative interpretation of a policy because folks are afraid of overstepping or doing something incorrect. And this is, I think, one of the reasons why folks are often afraid to adopt new technologies and protocols and processes because they're nervous that they're going to be not in compliance with the law. And so what I would encourage folks to do is not take the most conservative approach, because this is how folks get left behind. In particular, we know women get left behind, or people in rural areas get left behind, or underserved individuals get left behind. This is why we often see folks that are often Medicaid beneficiaries not get the support they need because people are afraid that they're going to not be in compliance with the federal policy. And I would argue that by leaving them out because you're worried about being not in compliance, you're actually doing worse by them. And so what we do is we work very closely with, I affectionately call our healthcare lawyers, to ensure that we are operating on offense so that we can help folks that are traditionally underserved and get clarity. And we also make sure that we are in compliance. And within compliance means that you're making sure that you're democratizing access to services. And I would encourage folks to take that little bit of time and effort to work with whatever lawyers or best practices or promising practices are out there, so that you're not just taking that most conservative viewpoint on it, and that you're leaning forward so that you're not leaving folks behind. We saw that in the federal government. There's often myths too, and those myths can further get compounded upon. So really take time to understand the policy, demystify it, and consult with the experts so that you can be on offense and improving access to services such as via telehealth.
Perfect. Thank you so much. I guess, Bronwyn, I know you used to work at a company that operated in multiple states. We kind of talked about the federal level, but at a state policy level, I know you guys had to juggle that as well, kind of particularly again when it came to women's health concerns and issues. What are some of the things that you ran into or problem-solving steps that you took?
Yeah, I think, if we could solve the different states' issues across the board, including board certifications, that would be amazing. Trying to think if there's specific, we definitely, you have to have a legal team to really understand and make sure that you're doing all of the right things in all of the different states. Of course, the certifications across the board. Availability is really challenging as you're trying to be available across 50 different states and thinking of the times and, what are they able to do in the different states. So I don't have a beautiful lesson. I feel like just there's a lot of challenges, and it's but I guess on the flip side, though, one thing is that, again, the convenience of someone being able to practice across different states, that is, there's some really small states, and going back to the, some people being left behind, that if we were, having a physical person, we'd be like, well, that's not enough for an individual person. So we did, things where you had kind of like pods of different states together, so you get people to have their boards, cross those ones, and they can cover the different patients, and so you can work with it. It's challenging, but I think it's still, the virtual side is better than having to have the challenges of in person for all of them.
Totally. And I guess Aditi, kind of bringing both, again, you've done a ton of work at the US level, but from an international level, what differences have you noticed? Do they do it better across the pond? Other unique sets of challenges? Sort of what's been both your US experience and kind of experience looking internationally?
Yeah, it's a great question. What I have learned, because all of what you said about the federal laws and the state laws, I agree with both of Andrea and Bronwyn. It is a nightmare in both ways, but obviously the information is out there. And I'll say, doing a lot of research on the US, what I find fascinating about it is that every model that you could see all over the world actually exists in some form within our country. Private payers, fee for service, the way the government models work are more akin to like the NHS than they are to other types of government models. So saying that, you'll look at a lot of the other countries, you actually will probably find a way to make it relevant to us and how we build it. Now, no country is exactly the same. And the way that they fix it or the way that they pay for it might be different. But in reality, most of the problems that we face in healthcare are going to be somewhat similar. Not exactly, not at the same scale, not at the same level of resources, but overwhelmingly the same, right? So we have everybody has issues of accessing care, whether it's because people live in rural areas or they don't have access, or they live in poverty, whatever it is, that there are access problems all over. There's not enough clinicians. There's not enough of a workforce anywhere, not really. Yes, a lot of the bigger cities might have enough for that area, but in general, there's not enough for any country. And then, of course, the entire world is seeing more aging and more chronic disease. Even if the population's not aging, there's a lot more chronic disease, diabetes and high blood pressure and all of those. And so when we look at, and then of course, we're talking about women here, and there's not a place I think that women get equal healthcare anywhere. Well, maybe in Scandinavia, but if any Scandinavians are listening and you have better statistics, please let me know. I don't know. But in general, I don't think it's the case because we are behind just in the research. And historically, we're behind, and it takes a while to catch up, regardless of what we do now in our policies now. And so telehealth in general has been tried and been thought to try to fix these same problems the way that we do in the US. So in that way, there's no mystery there. We're all trying to do the exact same thing. But again, we may not have the same ability to bring it out in the same way. So the UK, for example, despite the fact that it has a federal program, it rolls it out within provinces the way sort of we do it in areas or trusts, they would call it, similar to the way we do it. So they also have to look at the different laws, sort of like we do in the States. And so I would say that there's nowhere one place that I would say has the solution, but we can all learn from each other in various ways. But we're all trying to solve the same problems, and telehealth can solve a lot of those. Partially, it's not going to solve all of it, but it can be used to help in all of those ways. But what I have found, I'm going to use one example that I find very fascinating. It's from India because they have a huge population, definitely very big differences in access, but they've set up networks where they're able to actually take data and be able to figure out where is the right place for this person for transplant, for example. And they have a huge national network, and they use telemedicine for that. And it's an earlier use case for them. But I find that really fascinating because I don't know of anyone who has done it in such an organized manner. And it's something very specialized, and something that we could learn from, because I think we assume that we're further ahead than everybody. In a lot of ways, we are in telemedicine, I'll say that, but not in everything.
I actually like that idea. It's almost that idea of sort of that, we have some centers of excellence for generally surgical things, I think, but not actually for a lot of these kind of maybe specialized services, women's services and things like that. No, really cool idea. So people can do it, but we haven't quite, and again, I think a lot of that crossing state lines piece makes that piece a little bit difficult compared to when you have a nationalized, more nationalized health system. On that topic, and actually this is kind of for anybody, on the different problems to solve, issues to address in women's health, what's like the most important gap that you think women's telehealth or virtual care can help to bridge? Many things to solve, obviously, but if there's kind of one big one to tackle, I'll open this up to anybody.
Well, one comment I'll make is that, with the Barbie movie and Taylor Swift being in the news a lot lately, it's laugh, cry, funny how there's sadly this recognition of, wow, making entertainment for women is like super profitable and makes economic sense. And the same thing I would say with women's healthcare. Wow, when we support women's health, half the population, it's a good thing, right? And we see better health outcomes. And sometimes I think there's this narrative of, supporting women is philanthropy, when actually it's just darn good economic sense too. And it leads to better health outcomes, which allows them to, for those that want to be in the work environment, allows them to get back to work, for those that want to be working outside the home. And so in terms of supporting women's health and what we can do, and I know this is a little bit of a twist on your question, is let's actually reimburse it. And let's reimburse it, whether it's in person or telehealth. And if we can actually unlock reimbursement for these types of services and bring clarity to these policies, as an example, then we actually can enable it. And it's not just the right thing to do. We know that we'll get better health outcomes when we improve access to care, which can prevent things and also more urgently tackle any issues that are facing. And so what I would argue is that we need to be on offense, not defense, with supporting telehealth, because it can lead to more preventative care and getting more timely care, which can just help support women more broadly, getting back to work for those that want to, and it's the right thing to do for the long term.
Totally
I would
agree.
agree. I was just going to answer what it actually has helped do. From the research I've done, in generally, women tend not to take care of their health first, and they definitely don't take care of their mental health. And, during the pandemic, women, everybody used telehealth, but no, after everything's settled, women still account for most of the telehealth visits. So in the age range of, I think, 25 to 44, they're the most frequent users of telehealth. And between the ages of 45 to 64, they're the most frequent users for their chronic condition management. And they also use it a lot for virtual behavioral health. And so in general, it just opened up how many people are using it, because from studies prior to that, most women will say that they have their entire family get seen first, and they'll ignore their own health because of that. And telehealth has bridged that gap. But I'm also curious, Andrea, I wanted a follow-up question, because you said that you want women's health reimbursed. And the way that telehealth coding works and the way that telehealth reimbursement actually works is it doesn't specify in what cases the payment is for. It makes it for certain types of visits or certain screening or in RPM, certain devices. So I guess I'm curious, in what way do we want to make sure that women's reimbursement, what did you mean by that?
Well, a couple things there. So with regard to reimbursement with telehealth, there is just so many different questions. And we partner or are about to be partnering with a major academic medical center, These are thought leaders in the field. And our itty bitty startup has been coaching this major academic medical center on how to do reimbursement for breastfeeding support in our case. And specifically with us, virtual breastfeeding support. And they didn't know some of the basics with reimbursement of telehealth and reimbursement of lactation support. So two separate things, and we're coaching them on both together. And so we know that if, in particular in our case, women tend to lead organizations that help support women, and this is same with healthcare more broadly too. And so if we don't have folks leading these organizations or part of innovating in women's health, they often get left behind. So what we've been doing is trying to coach the existing infrastructure there on, hey, did you know you can use GT modifiers as one example to help code for this and get reimbursed for this telehealth? Did you also know you can use these E&M codes to reimburse breastfeeding and baby feeding support, which, by the way, is a requirement and a mandate under federal law that has yet to be enforced, but the White House last year said they're going to start having HHS enforce it. So I think it's insert men's health, women's health, whatever it is, but we need to have more people talking about what can get reimbursed, what is folks right under federal law to get reimbursed, but giving them the blueprint to do so. Because it's one thing to say how to do it, but it's the next thing to be able to give them the tools to execute upon it.
Oh, I understand now. I thought you meant we needed different codes. You're saying making sure that the codes that do exist for reimbursement are much more clear. I will tell you, I work on the committee that looks at CPT codes, and even we sometimes look at the changes and we talk to CMS and we get feedback on CMS, and even us sometimes are like, oh my God, what is going on? And so I will tell you, it's difficult for everybody.
Super hard.
Yeah. Yeah. I don't know why. Why can't just be easier? But I agree.
Oh, if only. I think that's why we have great minds on this call and elsewhere also trying to parse through these. And I think that coaching idea is 100% there, right? Where just because it's there doesn't mean it's going to get used, or it's going to get used in the way that those that wrote the law or the policy intended it to be. Bronwyn, thoughts from your end again on kind of where an important gap is? Again, you spent a lot of time on the virtual primary care side, but in anywhere along your kind of journey there, where can we insert some virtual care to close those gaps?
Yeah, to me, and this is, my bias or experience coming in is, I think there's a lot of gaps in between the visits that digital health can really step into, and that having the telemedicine visits is huge, because again, you're not asking someone to come in, hours, maybe potentially to get to a visit. And so experience, whether it is chronic conditions, whether it's mental health, whether it's actually having appropriate resources when you're needing to look something up and wonder, do I actually need a visit? Do I need a prescription? What are the things? How do I really manage that? And so I think there are relatively simple app-based experiences that you can do, and education as opposed to Googling. I love those mugs that, Google didn't go get their medical degree. There's good information on there, but it's hard for, individuals who haven't had training to really sort through that. And so I think there's just a huge opportunity there to tie it in. So you have the virtual visits, you have in-person visits, you have all of the tools that you need, but in between the visits, an individual is stuck there thinking, do I need help? What was I told to do? I'm trying to change this in my diet, but I can't actually even think of, what should I do on this or that? And then the power of data, whether it's blood pressure data that you're getting at home, whether it's logging symptoms so that you actually see, oh man, it feels like I'm getting migraines every other day, but it's actually twice a month. Or, I feel like my asthma is pretty well controlled right now. And then, actually, what? No, I've had 3 flares in the last month and my meds actually should be changed. But if you don't help to track that, then that interaction with your provider doesn't necessarily have the same output, because they don't have that information. And then the power of really just engaging the patient and helping them be empowered. So self-regulatory theory, I love, but monitoring, seeing, evaluating, making changes, and reinforcing those changes they made. So I think there's tons of work that we can do now. Not to go into a huge thing on reimbursement, that I think really there aren't great codes of, who builds those programs and those apps, and, health systems do that. Apple puts some things in their health app. There's different things. That part, I think the payment is not totally sorted out yet, but the ability to impact and engage patients in between visits and influence outcomes, that I feel like there's no question it's possible. With a well thought out app, it isn't just, kind of throw anything out there and, don't pay attention to how it, works and looks. And I think spoiled for my time at Apple that, gosh, a really good designer is worth their weight in gold.
Totally. And I think I've chatted about this idea, that idea of interstitial care, right? The stuff between the stuff, because CPT codes tend to be for encounters. Maybe you can kind of get like a remote patient monitoring code, but like 99% of them are like, what are you doing in a synchronous encounter, be it a video visit encounter or otherwise? And Brad and I totally agree that catching again, the same way that telehealth integrates into people's lives on a video visit, you can also integrate even more kind of in those lighter touch check-ins.
Yeah, and Matt, I'll say my one thing, the remote patient monitoring codes. I think lots of people thought, oh gosh, this is the answer. Look, you have the code for it. It is time-based. And so by definition, not scalable. And also takes away things if you're like, oh gosh, I can put a nice education experience in the app and maybe I have a curriculum, it's interactive, maybe even gamify it, something. You don't get paid for that. That actually took away from the, visit time. Like, so you're disincentivized to make your app experience better and more scalable. So I appreciate that they exist, but I think they aren't quite working the way that would be best overall to really support digitizing and scaling those interstitial experiences, as you say.
You're right. Bronwyn, if it helps, we're working on changing them. That's like one of the things.
Love it.
Awesome. Actually, pivoting on that a little bit again, a question for kind of the whole group or whoever wants to jump in. Kind of this idea is, and if we can kind of turn something into an app, be able to catch some things on the in between visits, where does that put kind of the virtual care companies in relation to traditional PCPs, traditional OBGYNs, and how do you kind of bridge that gap between the two without fragmenting care too much?
Well, I just want to first jump in and say our care is fragmented already, actually. And I think using the way just Bronwyn just talked about, that interstitial care and the visits between can actually help bring it back to a more cohesive manner, because we're going to have more data that we can share in person within our virtual care practices. The idea of care collaboration works really well with telemedicine. If you look at all of the studies on especially people with particularly complex cases or diseases, that's exactly what they do, and they have great outcomes or better outcomes, longer lives, etc. All the things that you want to see. And so I find that that's probably going to be the opposite, as long as we think of it that way. Because the reality is, we've all moved around. I've had different doctors, or you change jobs, you have to change your doctor, even if you live in the same place. Our care is already fragmented, and we could try and change that. That's fine. But I actually think the tech tools that we have are not going to change that, but we can use them to create this comprehensive picture for ourselves and to share it with our physicians and clinicians in general.
And maybe one thing I'll add on that, because I know it's so funny, I've worked with physicians, you get all of different, some people that are scared when they're hearing even that idea, right? All of this and more data. And then I've worked with other physicians who are like, well, I need real-time notifications, when someone, logs or headache or this or that. And so I think there is this balance, and you have to figure out, and surprise, I think it's somewhere in the middle. It is not, getting real-time notifications of things that patients log. That needs to be really clear. And I've had some doctors even describe it. Think of it like your paper diary at home, where you don't think your doctor is going to get, a magical message of that. You don't expect a phone call, from that. But then when you interact with them, hopefully, it's not the paper diary anymore. And you can actually, like, I get blood pressure ones where I look through, I'm like, okay, max, min, as I'm recording it into the EHR. But so how do you really bridge and do that? It's empowering the patient, but it isn't putting more burden on the provider. And then it needs to be summarized in, a useful way. So, and just like when I read Zeopatch or whatever heart rhythm monitors, there's a one-page summary that, really pretty much gives everything. Sometimes when there's a question, you kind of flip through and look at, the other ones, but that sort of thing has to exist for providers. So I think it's possible right now where it's like, oh, if you give too much information, it's not summarized, or you think, what, you should get an alert with everything. And then you still can do, even messages to patients. So say they put in a blood pressure that's, systolic is 185. You can actually do education within an app of, these are the, normal readings, and these are the symptoms to look out for. So it's not practicing medicine. It's not a provider telling you what to do, but it's giving that just-in-time education. And so I think there's so many powerful things that we can do. And again, kind of playing within, not expecting the doctor to be on in between all of these visits, but having the right information at the right time.
Yeah, I love and agree with what folks have said. And one of the opportunities I think there is to help facilitate exactly what Bronwyn was talking about was if we can further embrace smart on fire health IT standards and not fire like how the Gen Zs use it with the fire symbol, which I embarrassingly use like incorrectly all the time. But FHIR FHIR fire, where we can take that structured data and send that back exactly to the right place in the record so that it's not lost as, an image or a PDF in a clinical inbox, which just burdens providers and physicians in ways that are incredibly overwhelming, and it gets lost in the system. So how can we take that data and structure it right into the record so it's part of that note in a thoughtful way? Because the current standards with direct trust are, the intermediate way to get there, but it's inserting itself often and where it shouldn't be sometimes. And secondly, one of the things that we see as part of our care pathway is, is an appointment really needed, or is there an opportunity to offer that plain language content in a way that protects providers' time, but inserts in a way that can prevent another visit from happening, which, by the way, adds cost. And the example lately that I felt as a patient is I thought I had mastitis when in fact I had a clogged milk duct, but it actually wasn't a clogged milk duct. Turns out it was just inflammation surrounding the clogged milk duct, and applying, cold pack there helped prevent that. And, typically that would have been an emergency visit or presenting to the ER, but actually because I was able to text with one of our providers in a way that could support that. But then again, the question is, how do you reimburse that and support that, incentivize that, but also protect providers' time and physicians' time? So I think there's a huge opportunity to think about what this looks like. And it's so exciting to hear, Aditya, that there is work happening, because I think there's a huge opportunity to both save costs, improve access to care, but we're kind of living in this intermediate place in the meantime.
And if anyone,
Andrea, great.
oh, go ahead.
Oh, sorry. Other great examples are with chronic conditions, right? Someone's out of control, you make a change in a med, and you need to follow up in 2 weeks. But what if then their blood pressure or whatever it is actually well controlled? You just keep that visit. So yeah, there's a lot that could be done to help. Well, you can space out a visit, you can move up the visit, those sorts of things, and have it really be based on how someone's doing at that time. Yeah, I love it.
And I was just saying, if anyone here on this call or anyone watching this has figured out how to shoot that gap right in the middle, please let me know or us know. Because again, if we can get that, I think that'll perfectly balance the patient access to clinician sanity piece that we're all juggling these days. I really appreciate everybody's time. I'm actually going to go into a quick lightning round of questions. We'll just kind of go around the room a couple of times, and then we'll wrap up shortly. But first question I have, do you like the term femtech? And if not, do you have an alternative term? And I'll go to Aditi first.
Oh, man. I don't know how I feel about it. I feel like there's so many different terms running around there. There's like women's tech, femtech. I don't know if I have a preference or favorite. I suppose it depends on what you're working on. But yeah, I don't have a great answer. Sorry, not a great lightning round first start.
I do not like the term. I don't really know why. It just feels to me very like sterile. So I don't love it, but I also don't have a better term.
Yeah, I'm with the others. It's like, you know what, if it draws attention to it, gets investment, and it allows reimbursement and us to have a conversation, sweet. I mean, it's the same thing with telehealth. So back in 2010, people, like, the big mantra was telehealth is health. And right, we're seeing that now with women's health. Women's health is health. And it's like, well, if we have to live there for a little bit to get attention to it, sweet. And let's get away from it just because it like pink labels it, right? And as much as I love pink now because of the Barbie thing, all the things that are being talked about, but I do think there's an opportunity to move away from it, hopefully soon.
Perfect. I'm with all of you on that, and I don't have a better term for it yet. I think health is just the answer, right? Let's just call it regular health.
Yeah.
Next question is favorite person to follow for women's health news, be it regular women's health or women's health tech. We can go reverse orders, Andrea.
I mean, I love following Hallie Tecco. She does such a thoughtful job of summarizing all the latest, and it's such a gift to have that. And frankly, she does it often. She doesn't get I think the recognition she deserves sometimes, and does that because she cares. And so, definitely her.
I would say it's actually not in official news anymore now in VC world, but Chrissy Farr, I love her writing, and she definitely is a big proponent of women's health. Lots of other things she writes about too, but including telemedicine.
You actually took my answers. So, but I will say I have another one that I follow that I really like is Jessica Federer. She always has some interesting thought processes too. She's not specifically just in that, but it's a lot of the things she comments on as well.
Really cool. And then last lightning round question, and we'll go back in reverse order. Will AI replace clinicians, DT?
No, it'll help clinicians. So you have to learn how to use it because it's going to make sure that whatever work we do clinically is going to be easier, hopefully more efficient, and hopefully safer if we can ever figure out what the right algorithms are. But no, I don't think it'll replace them completely, but it will replace clinicians in some places. And so in that way, it might feel like they're being replaced, but no, not really.
Yeah, in my mind, answer is hell no. But can it being done in the right way actually help with a lot of the things that providers hates or takes a lot of the time? I don't think anyone wants some algorithm spitting out and telling them that they have cancer and here's their percentage of survival or different things like that. That I think the actual practice of medicine is there. But gosh, wouldn't it be nice to have, the data behind the conversation to have with a patient? Wouldn't it be nice to have your notes, written out for you that you're just checking? So in my mind, it's not a replacement, but when done well, can really help augment all of the time that providers spend and get them the resources that they need, at the time they need it.
Yeah. So it's 2023 and we are still using faxes pretty dominantly in healthcare. So whenever I see a blog post or an article that's like, oh, AI will replace healthcare, I just laugh. And I'm an engineer, my husband's a physician. And it's like, whenever folks like really do think that AI is going to replace physicians and clinicians, it's a signal to me that they actually don't understand healthcare because we're still using faxes. And I totally agree. It's a complement. It's an enabler. It's an augment. And that's the reality we're going to live in.
Awesome. And then my final question to everybody, thinking about ways that again, actually, different tools, technological tools can augment care. What innovation in women's health or digital health overall are you most excited to see in the next 5 years? Andrea, I'll go to you and we'll go back around.
I mean, just picking on the thread that we've brought up a lot is I'd like to see more innovative reimbursement models, right? And we're living in the current structure and it's where we need to live. It's how we get to change and change does happen incrementally in healthcare. So if we can think differently on what reimbursement models look like and have reimbursement models that support some of these use cases that we've talked about, I think that would be huge.
Yeah, and I'll repeat, I think it is this interstitial care or this, experiences. So we can facilitate telemedicine visits now, great. But how do we really get that experience in between that you can seamlessly move your records, your information, things beyond just what the actual visits are, to make the whole thing better connected and empowering the patient in between too. It isn't just the interaction between the provider and patient.
I'll say it's not necessarily the tech itself, but the outcome of it. So if we do have a lot of the data that we're sharing, we have the AI machine learning. I'm actually interested in seeing how these population statistics might change because the way that we do research now, we might be missing entire parts of what's actually useful for certain populations, for certain types of patients. I would be curious to see if we change our standard of practice or standard of care based on some of the data that we're going to be gathering over these next few years. And maybe we'll be able to do it faster, right? And this is what's happening in women's health in general. Things are changing faster because there's a commitment to it and there's more data out there and people are willing to invest in it finally.
Love it. Kind of this whole thread of policy, better data, using that data, putting it back into practice and kind of having a really nice virtuous circle there. again, I want to thank all of my panelists. It's super fun. Again, always fun to reconnect. And then I just always learn a ton every time I talk to any of you individually and definitely as a group. So thank you all for taking part in this today.
Thanks, Matt.
Thanks.
Having us.
Great to see you guys.